welcome everyone. Thank you for joining. This is our third CHAMPS Wednesday webinar in our spring series of 2021. And we are thrilled to be able to have a presentation by Dr. Eileen FitzPatrick today. The presentation will be called Updates from BabyFriendly USA, Launching Virtual Assessments and Revising Guidelines and Evaluation Criteria. And if everyone could just mute themselves, I think everyone already is. We're all used to the Zoom life now, but just to make sure that we can give our full undivided attention to Dr. FitzPatrick. Just a couple CHAMPS announcements. One is that we have one more webinar on June 23rd in our spring series, and this will be announcing our newest project, Mississippi Wins, which stands for Workplaces Improving Nursing Support. This will be led by Kathy Carruthers. She'll be joined by representatives from Greenwood LaFleur, Merit Health Women, Southwest Mississippi Regional Medical Center, and the Delta Health Alliance. Also, if you aren't aware, you haven't registered yet, our virtual breastfeeding conference is coming up on May 19th. And we will be offering ANCC nursing contact hours for this conference. So I will now pass it over to Dr. FitzPatrick. We are so thrilled that the new CEO of BabyFriendly USA could come and join us today and share some updates and introduce yourself. So let me stop sharing my screen.
Great.
Let me know if you can share your screen.
All right, let me just double check to make sure that I have the correct one. Yes, okay. Oh, so let me just, I apologize, share my screen. It's down here. We use so many different technical programs between Zoom and Microsoft and Webinar and WebEx. It's really wild. Okay, there we go. Okay, does everybody see that? Perfect. Okay, thank you so much for inviting me to be here with you today. The title of my talk is Updates from BabyFriendly USA, Launching Virtual Assessments and Revising Guidelines and Evaluation Criteria. My name is Eileen FitzPatrick. Thank you for the introduction. I am the new CEO of BabyFriendly USA. So I do disclose that I am an employee of BabyFriendly USA, and I have no other conflicts of interest to disclose. So here's a brief overview of my talk. I was asked to provide a little bit of an introduction to myself, so I will do that. I want to highlight BabyFriendly in the United States, as well as the BabyFriendly USA current accreditation process, which includes the virtual assessment for both designation and redesignation. I'm going to review briefly the 2018 WHO revised BabyFriendly Hospital Initiative guidelines and introduce you to the new guidelines, the BabyFriendly USA guidelines and evaluation criteria that are based on the WHO original guidelines from 2018. So I wanted to highlight the fact that my career has focused on maternal and child health the entire career. I am a registered dietitian, and I do have a master's and doctorate in public health. I like to highlight my doctoral work was on maternity care practices in New York State hospitals, along with breastfeeding. And I use the MINC survey, the Maternity Practices in Infant Nutrition Care Survey, as well as the PRAMS, the Pregnancy Risk Assessment and Monitoring System, to really look at maternity care practices in New York State and how they impacted breastfeeding. So simultaneously, while working on my advanced degrees, I did work both in academics and at the New York State Department of Health. At the time, CDC's, one of their primary intervention strategies for obesity prevention was breastfeeding promotion. And the first project I worked on was the New York State Breastfeeding Quality Improvement in Hospitals. And it was a learning collaborative utilized to enhance maternity care practices in hospitals to promote breastfeeding. And it really was the precursor. It was a CDC funded project, and it was one of the precursor programs for the Best Fed Beginnings, the 90 hospital learning collaborative that CDC had done. So that was a very exciting time. And many, well, not many, but a number of those hospitals in that initial cohort did go on to be baby-friendly designated. Also at that time, I did work on a community-based intervention that was CDC funded, and it was called Breastfeeding Friendly Erie County. It was a community, as I said, a community-based program in the most western part of New York State. And what we did then was really introduce baby cafes to that area of the state and the country. And we developed a certification program for breastfeeding friendly childcare, which was a really big achievement and has continued to this day. And then in addition to that, we did develop some guidelines and certification for breastfeeding friendly practices for OB and PEDS offices. That has not taken off as significantly as the breastfeeding friendly childcare, but certainly it is available in New York State. So that's me. So I wanted to highlight, the Baby Friendly Hospital Initiative in the United States. I think, all of us here can agree that babies are born to be breastfed. So I think to always keep that in mind is important. I wanted to show this graph. Certainly what we see here this is percent ever breastfed, or that's initiation in the hospital. And this is percent of live births in baby-friendly designated facilities. And you can see they're highly correlated. So if we feel very confident the positive impact that we're having on breastfeeding rates at baby-friendly. And I like to show this because it looks at the progress we've made over time, the timeline. So as of 2019, you can see that there were 600 baby-friendly designated facilities in the United States. So I'd like to make this a little interactive. The first poll question is, what percent of births in the US occur in baby-friendly designated facilities? So if you could launch the poll question, there we go, perfect. So I'll give you a few minutes to answer the question. Some of you may know this. Okay, it looks like things have kind of stopped. So the answer is 28%. So 48% of you did get that right. Yay. So we'll go on to the next slide. So I did round up just slightly. So 28% of US births, and this translates to over 1 million infants born in the United States. So it's a large proportion of the population that we serve. So the Baby Friendly Hospital Initiative is at essence, the evidence-based practice. It is the highest level, we find that the highest level of evidence-based practice is achieved with accountability. So that means, with accountability to Baby Friendly USA and our assessors. So it's important to note that when we look at hospital self-assessment, that it tends to overestimate the degree of compliance with the 10 steps. We provide, practice audits. So the Baby Friendly USA required practice audits that are used for quality improvement really demonstrate that oftentimes that the actual measurement of the practice shows that the hospital has overestimated their compliance. So that accountability makes a huge difference. The Baby Friendly USA accreditation process is shown to result in the highest level of breastfeeding metrics, for example, exclusive breastfeeding, when compared with hospital implementation alone. And Baby Friendly Hospital Initiative, Baby Friendly USA does provide a lot of technical support through feedback on infant policies, on access, as I said, access to the practice audit tools and reporting structures. So we really find that those practice audits used for quality improvement really help hospitals improve. So I wanted to, transition to what it means to become baby friendly and the importance of that. And I thought I would highlight some of the related information from Mississippi specifically. So as I was doing a little bit of research, there are currently 22 baby-friendly designated hospitals in Mississippi, and that's more than half of the facilities, the childbirthing facilities, and that is tremendous. So I do want to certainly, it's a huge advancement, and kudos to all of you who've been working so hard at this. So I also wanted to highlight the MPINC survey, and the MPINC survey, the most recently available data is from 2018. And I was really surprised to see that 91% of the hospitals in Mississippi participated. I shouldn't say surprised. I was really heartened to see that so many hospitals participated, because it really is utilized to assess how well we're doing nationwide. And I did want to highlight that, Mississippi in 2018 scored 73, which is a very respectable score. And my predecessor, Trish McEnroe here at BabyFriendly USA, had said that she spoke to a group similar to this a number of years ago and highlighted the 2013 MPINC, and Mississippi scored only a 59 at that point. So again, you've made huge amounts of progress improving your practices. And I also, I also wanted to mention, there was a 2019 CDC paper released that looked at disparities in breastfeeding between Blacks and whites, and the initiation for Blacks was 16.5% lower than for whites. And so that is certainly a concern, and one of our goals is to reduce breastfeeding disparities. And I'll quote Dr. Meerwood's recent paper that increased compliance with the 10 steps was associated with a decrease in racial disparities in breastfeeding. So I think this is really important to note, and one of the benefits certainly to pursuing baby-friendly designation. And again, this is a quote from a recent paper that was focused on experiences of nurses during the baby-friendly hospital initiative or baby-friendly designation process. And this direct quote I found very perfect for a talk like this. The BFHI process was hard, but worth it. And I hope we can all agree that that's the case. So baby-friendly assessment for designation. So as many of you know, if you're a member of the staff at a baby-friendly designated hospital or have gone through this process, entering the the 4D pathway is the first step, and then you will implement the 10 steps of successful breastfeeding, as well as ensure the compliance with the International Code of the Marketing of Breast Milk Substitutes. So then once that process has been done through the 4D pathway, you would invite the baby-friendly survey team to ensure or to verify that that's the case, that the 10 steps have been implemented and the facility is adhering to the code. Then you would undergo typically an on-site assessment, although we haven't done on-site assessments since early 2020. So we are now currently doing virtual assessments. And even during the virtual assessments, we do survey the knowledge and practice of staff and the experience of mothers and babies. So as a result of the COVID pandemic, we were forced to completely restructure the BabyFriendly USA accreditation and re-accreditation assessment process. We are doing them virtually. We did for them virtually in 2020, and now we will be doing them virtually through 2021. It was quite an effort to ensure the safe and accurate transition to doing assessments virtually. And I wanted to highlight some of the technologies we've done to ensure the safety and security of information from hospitals. We use Microsoft OneDrive for upload of materials for our review, and we use Microsoft Teams for all the interviews, all of which are HIPAA compliant. And we've designed things so that we avoid any kind of transfer of private health information. So it is safe and secure for assessments. So we've broken up the virtual assessments into two parts. So for the virtual assessment part one, you can see here we provide lots of support for hospitals going or any kind of facility going through the assessment. This is the virtual assessment checklist for part one. It includes the administrative, leadership, and purchasing agent interviews It includes healthcare provider interviews, staff interviews, and materials review. And the materials reviewed are infant feeding policy, patient education materials, and training documents. So for the virtual assessment part 2, it's more focused on the mother's experience. So we do mother's interviews that are, for pregnant mothers, if there are affiliated prenatal services that the hospital has. We also interview postpartum mothers and mothers of infants in special care. The second component of the virtual assessment part 2 are observations, and this includes the required 10 steps posters, the signage, and also photos of formula storage, which for the well baby nursery as well as the NICU. And then the final component of part 2 is reassessment of any non-compliant issues for part 1, but that is only for hospitals that had non-compliant issues from part 1. So I'll update you on the assessment status. To date, we've done more than 70 part 1 virtual assessments. So many hospitals have gone through this process. We've had very positive feedback from hospitals that it was smooth and not challenging at all as far as the process goes. We are continuing to do part 1 virtual assessments. As I said, these are ongoing. And we are currently scheduling for part 2. And these part 2 virtual assessments will be beginning the first week of May. So for any of you, those of you that are prepared for part 2, please submit a request letter and we'd be happy to send you dates. So we are scheduling through the end of 2021. So, and it is always important to note that post-designation, your success is a journey, not a destination. Achieving baby-friendly designation is certainly an important part of that journey, but is not the end point. So we require ongoing data collection and monitoring of practices. These quality improvement activities are vital to ensuring that baby-friendly standards are maintained. Facilities are responsible for ongoing adherence to our current guidelines and evaluation criteria. And we find that, certainly that hospitals that don't do this or are not up to date on this, that practices do slide backwards. So this is so important to maintaining practices for the best provision of care to our mothers and babies. So I'm going to highlight here the 2018 WHO revised baby-friendly hospital initiative guidelines. And I'm going to show you that this is the document that WHO released in April 2018. And so as this is an implementation guidance, it's a strategy or a series of strategies that can be used to implement a recommendation about a health intervention. So this is the document that BFHI is used to guide national authorities on how to update their program. So for example, BabyFriendly USA would use this to update our programs, and we've used it to update our guidelines and evaluation criteria. So this is our new guidelines and guidelines and evaluation criteria are based on this document. So as part of this new WHO document, the 10 steps were revised. So what has changed? And I'd like to show you here in red are the major changes that occurred between the 2016 and the 2018 version. So first of all, the International Code of Marketing Breast Milk Substitutes is now part of step 1, as well as ongoing data management. Step 2 is ensure that staff have sufficient knowledge, competence, and skills to support breastfeeding. Step 4 has changed from breastfeeding within the first hour to uninterrupted skin to skin. And step 9 has changed slightly to counsel mothers on the use and risks of bottles, teats, and pacifiers. So I have a second poll question to provide to you. So which step change will be the most challenging to implement? So if we could launch the poll, there we go. Okay, I think that, oh, it's still moving. Maybe just another 20 seconds or so. Wow, so that's, yeah, pretty evenly split. I think it depends on I guess we can close it now. Yes, so interesting. People rated step 4 as the most difficult. So in some cases, as far as competency verification for practices of placing the mother skin to skin. Great, thank you. So again, I think it's perception and experience as to which you think is most difficult. What we've heard from many people that are familiar with the WHO document is that step 2 will pose probably the most challenges because it's such a maybe diversion from the original training curriculum that was required. So I'm going to just talk briefly about the step 2 paradigm shift. Oops, I'm going to stay back here for a second. So we received guidance from WHO UNICEF in August 2020 regarding the step 2 and what they envisioned as the revised step 2. Our goal is to make the task for implementing the new step 2 as easy as possible, while still achieving what its intended outcome is. And the intended outcome is really to ensure that staff have sufficient knowledge, competence, and skills to support the breastfeeding in the way that the BFHI is designed. So there is a competency verification toolkit, and I know there's a lot of information on this slide, but these two, Annex A and B, are basically the competency verification annexes. They're the same document, just sorted differently. So in the US, I believe most facilities will find that sorted by BFHI step is the easiest to use. Again, these two documents here are the same. It's the examiner's resource. It's just that they're sorted differently. And again, it's likely that the BFHI step sorting scenario will be most easily used by hospitals in the United States. This also includes multiple choice questions with their answers, case studies with answers, as well as observation tools. So it's important to define competency. So competency is the capability to use a set of related knowledge, skills, and behaviors to successfully perform identified jobs, roles, or responsibilities. So, we have to get away from thinking that competency and learning objectives are the same thing. So learning objectives are really the expected goal of an educational experience, whereas competencies, so knowledge acquisition is very different from competency, or your ability to perform a behavior or a practice. So competency is more about the ability to versus the knowledge of. I think that's how I like to really look at it. So here is just reiteration of what I just said. That training and learning objectives, you have learning objectives that provide what the learner is intended to learn, whereas competencies are really looking at the outcome, what the learner is able to do. So the challenge was for those developers of the WHO document is how to measure competency. And so in this document, there are performance indicators, and there are a total of 64 performance indicators. This is the international document. The BabyFriendly USA has added a couple that are very particular to the United States. Let's move this a little bit. So these performance indicators, really evaluate knowledge, skills, and attitudes. So they're geared towards, guiding staff to safely and compassionately deliver evidence-based care. So I want to give a little bit example here. So here's performance indicator number 11. A lot of the performance indicators really evaluate foundational skills, many of which are related to communication or conversations with patients and mothers, patients who are mothers. So communicating in a credible and effective way is an important component of delivering, evidence-based care. So these foundational skills are related to counseling and patient interactions. It's important to effectively deliver individualized, safe, and compassionate care. And the caregivers really need to know how to, talk to a mother, how to have these conversations. So using the performance indicator number 11 that says demonstrate at least 3 aspects of listening and learning skills when talking to a mother. And you can see the appropriate responses listed here. Ask open-ended questions, use responses and gestures to show interest, reflect back what the mother is saying to verify what the mother is saying, empathize, express what you're understanding of how she feels in a culturally appropriate manner is important, and avoid words that sound judgmental. So these are the correct kind of observations that would occur, and these are here in red are examples of responses or behaviors of concern. And then the last column are resources. These are international global resources that are available for this performance indicator, sorry. So I wanted to highlight the breastfeeding counseling component of this. The WHO breastfeeding definition for counseling is a process and interaction between counselors and pregnant women or mothers. And I want to highlight, for BabyFriendly USA, we've really been working towards ensuring that the competency verification for communication includes definitions such as meaningful conversations, delivering compassionate care based on human interactions, connecting emotionally, considering others' perspectives, collaborating with the patient, making compromising and celebrating a decision regardless of what that decision of the mother or family is. And this is consistent with shared decision-making, which is a form of non-directive counseling in which the division of power shifts the conversation from giving patient education to exchanging information to help the family or the individual reach their goals, their desired goals. So with that, I'd like to move forward and talk specifically about BabyFriendly USA guidelines and valuation criteria, which I said are based on those 2018 WHO documents and where we are currently with the new GEC. So just to provide a little history, as I said previously, the WHO document came out in April 2018. In May 2018, we crosswalked the 2016 GEC to the 2018 implementation guidance. We identified new standards that needed to be implemented immediately, and those were related to step 9, pacifier use. So we rolled out version 2 of the 2016 GEC in July of 2018. We then convened an expert panel to further develop our guidelines and evaluation criteria. And that consisted of MDs, RNs, IBCLCs from across the country who had experience providing technical assistance and support to large numbers of hospitals with implementing the 10 steps and achieving baby-friendly hospital designation. And I have to mention that CDC was also included in this process. So we developed a first draft through our clinical director and clinical committee. It was reviewed by both the clinical committee and the expert panel. And the second draft was generated by the clinical committee. So as part of this process, I think it's important to note that we requested feedback from 7 national professional medical associations. And these included the Academy of Breastfeeding Medicine, the American Academy of Family Physicians, the American Academy of Pediatrics, the American College of Nurse Midwives, the American College of Obstetrics and Gynecologists, the Association of Women's Health, Obstetrical and Neonatal Nurses, and the United States Lactation Consultant Association. And this feedback was brought back to the expert committee meeting. So most of the materials were ready to go or completed by September 2019, but we were still waiting for guidance from the WHO regarding implementation of step 2. And that was released on August 5th, 2020. So certainly in between those dates, I put these mini explosions here because COVID happened, and it really delayed some of the work that we had been doing and we needed to transition or pivot to, making our assessment process or our accreditation process virtual and not in person, or not on site. So that was a little bit of an interruption, as it was for almost all of you in your work. But then we did, continue the work and did integrate the information acquired from WHO, as I said, that had been released in August. So we worked quickly, I think, to complete that. The issue with the COVID pandemic was significant, and with the conversations we've had with hospitals during the pandemic, we've had a lot of hospital support calls where we've reached out to hospitals to provide support, to accommodate when necessary, because some of the hospitals that are designated and members of our organization really had a challenging time during COVID. So whether it was staffing issues, either staff sick or staff out quarantined or staff reassigned, there were financial issues, and there were also even some, movements into different buildings. The labor and delivery was moved into different buildings. So we decided it was not appropriate time to release new guidelines. So we held off and decided to wait until summer 2021, which is upon us almost, to release the guidelines. This was announced in October 2020, and we will be releasing the new guidelines in July 2021, this year, in a few months. So not only did the guidelines evaluation criteria need to be developed, but there also was the necessity, kind of behind the scenes, to update all of the materials that we use and provide to hospitals. So this is all the 4D pathway materials, as well as the redesignation, the annual quality improvement materials. I won't, read these all to you, but they are extensive, and there's over 100 documents that needed to be revised to be, consistent with and align with the new GEC. So for now, assessments will continue using the interim GEC until the new GEC goes into effect. Facilities will be given time to incorporate the changes prior to assessments being conducted with the new GEC. And we anticipate that assessments with the new GEC will not occur until 2023, and likely sometime later in 2023, although that has not definitively been determined. So to give you a little preview, this is our working cover, the 2023 guidelines and evaluation criteria that we will be launching this summer. I do want to, so that's great. We're very excited, and we hope you love them as much as we do. I do want to discuss, because this has come up, the focus on safe implementation of practices that's part of the new GEC. So you can see this slide here. As we developed, the sections for each of the steps, safe implementation of practice was one of our focuses, and we consulted existing, clinical guidance documents from recognized professional medical organizations, in addition to consulting our expert committee. So for each step in the new GEC, the 2023 GEC, there is guidance on the step implementation, on the safe implementation of that step. BFUSA is dedicated to addressing concerns and providing support for the safe implementation of care. So this is one of the documents that we have utilized as part of this safe implementation of care. We did work with ABM on the development of this policy. It does meet most of our requirements. However, it is a global document, so it doesn't have 100% of the US specific items, but it does include some guidance on safe implementation, and that includes certainly skin to skin and rooming in. So those are important to note. Again, we also utilize this AAP clinical guidance, the safe sleep and skin to skin care in the neonatal period by Lori Feldman Winter. So we did, include this in our process. So there is a critical role for hospital staff and providers in supporting breastfeeding. One of the beauties of step 2 is it really requires that staff have the competency and the training necessary to provide the steps as intended. Safe and compassionate implementation of the practice steps that support breastfeeding are, the steps that are embodied in the 10 steps of successful breastfeeding. So it's crucially important that we support that and highlight that. And I'd like to, close by saying a million thanks from the more than a million mothers and babies that you care for. And I think at this point, I'd be happy to take some questions.
Thank you so much. This is Maytal again. Thank you so much for
I
that
can
great
stop sharing.
presentation.
I can stop sharing, I think. Oh, there we go. I guess I can stop sharing unless you need to restart. Are there any questions?
Yeah, so if you have any questions, feel free you can chat them in. I can read them out to Dr. FitzPatrick, or you could just go ahead and take yourself off mute and ask whatever questions you might have.
So I will comment briefly. There was, as I said, it was a Dr. Muirwood paper, I believe, that looked at nurses' perception. Oh, no, she was one of the authors, but looked at nurses' perceptions of the BabyFriendly BabyFriendly USA accreditation process, and how they found it hard, but well worth it. There were also some, concerns about, safe implementation of care, and certainly, we stand by our practices, and we support the safe implementation of care, and this is highlighted certainly in the next GEC, the 2023 GEC. There are no questions. I see
There's one
something
question.
In the chat.
Yeah, from Linda McGrath.
Slides. I can make my slides available. Yes. What is the ABM protocol used? That's it's a policy. It's for the infant feeding policy. Basically, it outlines everything needed in the infant feeding policy. Let me pull my slides back up. So the Academy of Breastfeeding Medicine has protocols, and let me see. And number 7, which I showed on my screen, is their infant feeding policy. I think I can share it again. Let's see, where is it? There it is. So if you can see that, so this is the model maternity policy supportive of breastfeeding. So it covers all the steps. Sorry. It covers all the steps. It's a model policy. Does that answer your question? Thank you. Okay. There's a link to the protocol. All right. Is anyone in the process of becoming baby friendly, working at a facility in the process of becoming baby friendly? Maybe many of you. Redesignation. Great. In 2022. Well, so if anybody's interested in what assessment is going to look like in 2022, that hasn't been completely decided yet. There is the potential. We have had requests. We have had requests to keep part 1 a virtual assessment, and part 2 the on-site component. I'm waiting for part 2 virtual dates. Great. Oh, that's so exciting. Redesignation. Excellent. We're waiting our second virtual visit, right? We had our first virtual visit. So hopefully, everyone in this meeting did have a good experience with the virtual part 1. As I said, I think in some cases I've heard that it went so smoothly that people want us to continue doing part 1 virtually and only come on site for part 2. So we have to ensure the integrity of our process. So certainly being on site is important, at least for part of it. And so we'll determine that hopefully by the fall. So local hospital, Starkville, and that's baby friendly. I would have to look up, whether the Starkville, Mississippi hospital is baby friendly. So that's a very good question. You can find all designated facilities listed on our website, babyfriendlyusa.org. Let's see, will part 1 and part 2 both be in our redesignation year? Yes, they should be. So what is your redesignation year? If it's this year, yes, we are trying to complete both part 1 and part 2. And in 2022, yes, they will both be in that year. Initially we developed part 1 and then developed part 2. So that's why there's a little bit of space in between them. We are hoping as we move into 2022, if it is still a hybrid model, that they will be closer in time, or at least be maybe at the same time. Great. Sure. You are welcome. Any other questions that I can answer? We have some great stories from the field. I don't know if it does seem like there are a lot of hospital staff in this meeting. I've spoken to a number of hospitals, and one of the issues was, with reduced visitors due to COVID, that their breastfeeding rates and their rooming in was going really smoothly. The mothers were less tired, not interrupted as much, and there wasn't so much influence of outside people. So I don't know if anybody else has had that experience, but it certainly helped with those practices. And we found that that was the safest thing for mothers and babies, to be together and to be left. I shouldn't say left on their own. Certainly we provide the care and the oversight, but to keep them uninterrupted, to bond in that early postnatal period. Any other questions?
Is anyone else?
Yeah, such great work being done in Mississippi. Yes, I completely agree with that. I'm so impressed. When I looked at the numbers, it was very, very exciting. And for those of you in other states, I will be looking at you also. Anything else? Let's see if there's any. So we will have decisions on what the 2020 assessments look at probably by early fall. Those decisions will be made, so we will let everyone know as soon as possible. But we are expecting to at least have an on-site portion of the assessment. Okay. All right, new message. Thanks for supporting. Oh, we're so excited for hospitals to become designated. So welcome. And again, if you are at a facility and you need support, please, we have resources to answer questions. I know we have email addresses that people are aware of, but if you need additional support, please contact us. We're happy to do that. Okay. Anything else I can?
Questions?
How many in the US are baby friendly? So currently there are 591 hospitals that are designated baby friendly in the US. And I believe it's sometimes hard to pin down exactly how many maternity care facilities there are in the US, because it changes with mergers and acquisitions. And we've had some closures, some temporary closures, some permanent closures. But there's likely in the 3,000 range of maternity care facilities in the United States. So out of those, 591 are designated baby friendly. We're down just a little bit from 600, which we really attribute to COVID. As I said, there are some facilities that have temporary closures, permanent closures, relocations. So a number of facilities have had to leave the program, hopefully just temporarily, and come back when they're more able to institute the practices in the way that's required. Does that answer your question? So my niece this is again about Mississippi, and I'm not, my niece moved to northern Mississippi as a result of a military move. And I was so pleased to find out that there was a baby-friendly hospital, because she's going to have a baby in September in her town. Meridian, Mississippi is where she is. Okay. And again, some of this information is on our website. We have the listed of designated facilities by state. So you can certainly, search for those facilities on our website.
I have one question. Oh,
okay.
There's one friend.
Yeah, is there anyone at the meeting who is not a baby-friendly but wants their hospital to start the process? Oh, that's a very good question. So if there is, you can certainly reach out to me, and I can direct you as to how to begin that process. And even if you just want inquiries as to what it might take and what you would need to do to get started, please email me and let us know.
I have one other question. It's a bit,
yes.
It's not exactly on the same kind of thread of what you've been saying so far,
Okay.
But one of your slides had said that talking about the 2018 BFHI implementation guidance and saying that the implementation guides are not guidelines. And I'm just wondering if you could speak a little bit to kind of how hospitals and facilities and just people reading guidelines versus these implementation guidance, like how you see those as different in viewing them and reading them.
So the WHO implementation guidance really are recommendations as to the practices of how it should be implemented. What we need to do as far as an accreditation organization is we need to develop not only the how to implement, but also how to measure. So we have evaluation criteria that are associated with each component, with each criteria in the guidance. So we stick very close to the WHO guidelines and guidance. Only on rare occasions when things are very specific to the US do we add any additional criteria, but the evaluation component is how you're going to measure it. So what data are you going to use to verify that criteria has been met? So a lot of what we're doing, what we have done for our new GEC is utilizing the new guidelines from WHO, but also developing all the criteria for how each of those is going to be measured, which was actually a significant amount of work. And so I know we've been a little bit delayed, but between the significance of the volume of work and, with all the background documents that also had to be changed, kind of a domino effect, in addition to that, and then the pandemic. So it has been a challenging couple of years.
Thank you so much for answering my question and undertaking all of this work. Okay.
Sure. Did that sufficiently answer your question?
Definitely. Yeah. Thank you.
Okay. Great. You're welcome. All right. Anyone else I just want to ask any other questions? So I think, again, I don't want, any hospitals that are in the process or, getting ready for, they're either in designation or redesignation process. We are trying to make the step 2 certainly, and the other steps also, but step 2 has been highlighted as most challenging, trying to make it as easy as possible for you and making sure that our documentation is clear so that there's not an issue with understanding what will need to be done for that step. So, and we're not trying to make it difficult. We're just trying to meet the requirements of the international guidelines. Right.
Well, thank you so much.
Oh, you're welcome. Thank you for having me. I really appreciate the opportunity.
And just putting up our last slide, just that thank you for joining, and be sure to join us on May 19th for our virtual conference, and then again in June for our next webinar. Does anyone have any last burning questions? If not,
No.
okay. Well, if you think of any, you can feel free to reach out to the CHAMPS team, and we will pass them along to Dr. FitzPatrick after the webinar.
That would be
Thank you
great.
all so much for joining,
Okay.
and hope to see you all soon.
Thank you.